Good morning, and thank you for logging in to view Therapeutic Approaches to Managing Withdrawal. This webinar is brought to you by the New Hampshire Training Institute on Addictive Disorders. You can access the recording of this webinar on our website at www.nahatica.org. After completing this webinar, please upload and complete the quiz if you're interested in receiving a certificate. You can find the quiz in the file pod throughout this presentation or on our website at nahatica.org, or you can email us at thetraininginstitute@nahatica.org. You can email, mail, or fax the completed quiz. Contact information is on the quiz itself. If you're a member of NHATICA or NADAC, the certificate for this webinar is free. If you aren't a member, the fee is $15. You will receive a certificate worth 1 CE once you have completed and passed the quiz and paid for the webinar, if applicable. Throughout the Training Institute on Addictive Disorders, this event is pre-approved by the New Hampshire Board of Licensing for Alcohol and Other Drug Use Professionals, as well as the MBCC. If you have any trouble viewing this webinar, audio problems, or have any technical questions, please contact us at 603-225-7060. Please email any questions regarding the material you see today to traininginstitute@nahatica.org. You can file and upload these introduction slides in the file pod to the right of your screen. And with that, I'm going to pass you on over to
Welcome to Therapeutic Approaches to Managing Withdrawal. My name is Teresa Gleason, and I'm a registered nurse with a background in mental health and addiction. Most recently, I worked as a health and wellness specialist at a 28-day inpatient rehabilitation center. It was there that I witnessed firsthand the distress that individuals with substance use disorders experience during the withdrawal and post-acute withdrawal periods. My plan for today is to share with you the most current medical and non-medical methodologies for treating clients in the withdrawal phase of early recovery. As we begin, I want to emphasize the suffering of the individual going through withdrawal from drugs or alcohol. To walk through the door of the treatment center takes incredible active courage, often combined with a sense of desperation. I just can't do this anymore. I'm sick and tired of being sick and tired. These are sentiments expressed by many clients who enter treatment. They are surrendering the substances that often are their primary means of coping. I believe that the most important thing we can do as caregivers is to instill hope. In the words of Helen Keller, although the world is full of suffering, it is also full of the overcoming of it. After the completion of this webinar, you as a learner will be able to identify the signs and symptoms of acute withdrawal from alcohol, opiates, stimulants, and benzodiazepines. You will become familiar with the assessment tools and detoxification protocols most commonly used for the treatment of alcohol, opiate, and benzodiazepine withdrawal. You will also be able to define the post-acute withdrawal syndrome and list comfort medications used to manage the symptoms associated with pause. You'll be able to discuss the role of pause plays in relapse and explain the use of anti-craving medications in helping to prevent relapse. In addition, together we'll explore some of the alternative approaches to managing pause. According to the Substance Abuse and Mental Health Services Administration, continued exposure to alcohol and other drugs induces adaptive changes in the individual's brain cells and neural functioning. The changes vary depending on the drug of abuse and are not completely understood. The term neuroadaptation is often used to refer to these changes. One result of neuroadaptation is drug tolerance. That is, increasing amounts of the drug are required to produce the same effect. A second consequence of neuroadaptation is physical dependence. The brain cells require the drug in order to function. The sudden removal of alcohol or another drug of abuse from the system of a person who is physically dependent produces either an abstinence or withdrawal syndrome. The American Society of Addiction Medicines defines withdrawal as the onset of a predictable constellation of signs and symptoms following abrupt discontinuation of or rapid decrease in the dosage of a psychoactive substance. The onset of withdrawal from alcohol generally occurs between 6 and 24 hours following the last drink. For benzodiazepines, withdrawal symptoms appear 12 to 24 hours after the last dose. For opiates, 8 to 12 hours following the last use. Let's begin this slide by differentiating the term sign from the term symptom. These are often grouped together. A sign is an objective and observable or measurable, such as elevated blood pressure, rapid heart rate, and tremors. These are all signs that the healthcare professional can observe and monitor. Symptoms, on the other hand, are subjective experiences of the client, such as body aches, pain, and anxiety. Drugs are categorized into groups, such as opioids, sedative hypnotics, and stimulants. All opioids, which are derivatives of opium, as well as those that are synthetically produced, will produce a common withdrawal syndrome. For example, the symptoms of methadone withdrawal are similar to those of heroin withdrawal. However, the signs of heroin withdrawal begin quickly and peak rapidly, whereas withdrawal from methadone, which is a long-acting opioid, begins slowly and lasts longer. In general, the signs and symptoms of withdrawal from a particular substance are the reverse of the desired physiological effect. For example, alcohol and sedative hypnotics produce decreased anxiety and sedation. Cessation of these substances in a person who is physically dependent will produce anxiety and insomnia. Detoxification is the process through which a client who is physically dependent on alcohol or other drugs is withdrawn from that substance. Many clients with substance use disorders are addicted to a combination of drugs and/or alcohol, so detoxification may involve more than one substance. Detoxification includes a period of time during which the body's physiology adapts to the absence of the drug. In addition to alleviating the short-term symptoms of withdrawal, the primary goal of detoxification is to provide a safe withdrawal from the drug of dependence and enable the patient to become substance-free. For someone who is severely dependent on alcohol, unsupervised cessation may result in delirium tremens or death. Sedative hypnotics can also produce life-threatening withdrawal syndromes. On the other hand, withdrawal from opioids while producing severe discomfort is not life-threatening. Another goal of detoxification is to provide withdrawal that is humane and protects the patient's dignity. A caring staff, a supportive environment, sensitivity to cultural issues, confidentiality, and the selection of appropriate detoxification medicine as needed are all important to providing humane withdrawal. Lastly, the detoxification period is an opportunity to prepare the client for continued care, to offer information, and to help motivate them to engage in longer-term treatment. As previously mentioned, with alcohol, the physiological effects that are desired are decreased anxiety, sedation, often leading to sleep, can also cause coma and respiratory depression, whereas the withdrawal symptoms are increased anxiety, agitation, insomnia, and with severe withdrawal, hallucinations and seizures. Here are some examples of the effects versus the symptoms of withdrawal from opiates. A person withdrawing from opiates might experience dysphoria as opposed to the euphoria produced by the drug. Likewise, opiates decrease anxiety, and during withdrawal, the client will experience increased anxiety. Likewise, analgesia, patient may experience pain and discomfort. The physiological effects of opiates are also to decrease the activity of the large intestine, resulting in constipation. And during withdrawal, many clients experience overactivity of the large intestine, resulting in diarrhea. The time frames for acute withdrawal are as follows. Alcohol generally takes 5 to 7 days. Opioids, 4 to 10 days. Benzodiazepines, 1 to 4 weeks. Stimulants, 1 to 2 weeks. Nicotine, 2 to 4 weeks. And cannabis, 5 days. As you can see, withdrawal from cannabis, alcohol, and opiates is relatively quick, a matter of days, whereas detoxification from benzodiazepines, stimulants, and nicotine can take substantially longer. Moving on to the medical management of alcohol withdrawal syndrome. The setting for alcohol detoxification is in part determined by the patient's needs, the severity of withdrawal symptoms, and the intensity of care required to ensure appropriate management. Insurance carriers and managed healthcare organizations have a significant effect on the selection of the treatment setting and the length of stay. Medical model programs are directed by a physician and staffed by other healthcare personnel. Detoxification can take place in an acute care hospital, a psychiatric hospital, or a medically managed residential treatment center. The mild to moderate symptoms of alcohol withdrawal syndrome can be grouped into 2 categories. Those that are the result of autonomic hypersensitivity, and those that are related to neuropsychiatric changes in the brain. The autonomic nervous system is the division of the nervous system that regulates involuntary body functions, such as heart and breathing rates, and digestion. These symptoms usually start a few hours after cessation of drinking and peak between 24 and 48 hours. Some of the autonomic nervous system hyperactivity of alcohol withdrawal can be ameliorated by medications such as propanol and atenolol. These drugs block beta-adrenergic receptors. While decreasing autonomic symptoms, beta blockers do not prevent hallucinations and confusion or withdrawal seizures. The second group includes symptoms of neuronal excitation and usually occurs 2 to 4 days after cessation of alcohol. If left untreated, withdrawal syndrome may progress to severe and potentially life-threatening conditions. Seizures, while included as a later sign of alcohol withdrawal, can occur at any time and may even be the first indication that a patient is in withdrawal. This is especially true in people with a history of seizures. Patients who develop delirium tremens with hallucinations may need antipsychotic medications to ameliorate their hallucinations and to decrease agitation. Haldol generally controls symptoms and can be given orally or intramuscularly. Thorazine should not be given, however, because of the increased risk of seizures. Alcohol-dependent patients may also have vitamin deficiencies, particularly of thiamine. Patients should receive thiamine in addition to a high-potency multivitamin. CIWA, or the Clinical Institute Withdrawal Assessment for Alcohol, is not copyrighted and may be used freely. It takes from 2 to 5 minutes to administer and allows clinicians to rate 10 signs and symptoms. The areas of assessment are nausea and vomiting, tremor, paroxysmal sweats, anxiety, agitation, tactile disturbances, auditory disturbances, visual disturbances, headache, and orientation to time, place, and person. The maximum score is 67. This assessment should be done every 1 to 2 hours to monitor the patient's progress. Increasing scores indicate a need for additional medication. Decreasing scores represent therapeutic response. Patients who score less than 10 usually don't need additional medication. In a 2014 review of the literature in med-surg nursing, Reagan Skinner conducted a comparative analysis of studies on the efficacy of symptom-triggered versus fixed dosing schedules for the medical management of alcohol withdrawal. According to Skinner's research, benzodiazepines, otherwise known as sedative hypnotics, are the only medications recommended for the treatment of alcohol withdrawal syndrome. The most commonly used medications are Librium, Ativan, and Cirex. With symptom-triggered management, patients are assessed using the CIWA-AR scale. The dosage of the medication is determined by the patient's numeric score. Whereas with a fixed dosing schedule, medication is administered at scheduled times and then slowly tapered. Skinner concluded that in studies using fixed dosing schedules, patients were at a greater risk for adverse medication reactions such as oversedation, immobility, prolonged hospitalizations, and possible unnecessary costs. The studies she reviewed demonstrated that symptom-triggered therapy is as effective as fixed dosing schedules in treating alcohol withdrawal syndrome, and it can also decrease the need for benzodiazepine and reduce the number of days of treatment. It's important to keep in mind some of the possible medical complications of alcohol withdrawal. Maintaining a patient's fluid and electrolyte balance is of key importance during detoxification. Most patients can be given fluids orally, beginning with juices and progressing to other liquids such as soups. Patients who are vomiting or having severe diarrhea should first be treated with sips of liquids that contain electrolytes. The amount can be increased if fluids are tolerated. Patients who become dehydrated should receive IV fluids containing electrolytes and dextrose as well as thiamine. Hypoglycemia, or low blood sugar, is a significant danger during detoxification. Oral fluids should contain carbohydrates, and orange juice may be one option. Any elevation of temperature in an individual who is undergoing withdrawal should be investigated. If the elevated temperature is a result of withdrawal, there is a need for other medication and reevaluation of the detoxification schedule. If a patient has no other signs and symptoms of withdrawal, the elevated temperature is probably caused by an infection. An early aggressive antibiotic therapy may be necessary. While medical concerns must be addressed first, any underlying psychiatric disorders must be dealt with as well. Failure to do so increases the risk of relapse. Suicidal patients can be detoxified, but they should be placed in an acute inpatient psychiatric setting rather than an outpatient setting. Certain drugs of abuse and certain medications used in detoxification may interact with others. Therefore, it's important to be aware of any other medications that the patient is taking and to consider possible drug interactions. In addition to the above, patients should be assessed for trauma, including bruises and lacerations. Because of their decreased level of consciousness, severe alcoholics may not even realize that they've been injured. And now it's time for a discussion question. Patients scoring less than 10 on the CEWA scale usually do not need additional medication. True or false? The answer is true. Patients who have been assessed every 2 to 4 hours and medicated according to the CEWA scale will show a gradually decreasing need for medication based on their signs and symptoms. Once the CEWA scale is showing a score of less than 10, these patients will not need additional medication. Let's talk a little bit about some of the comfort medications that are used for the treatment of alcohol withdrawal syndrome. For anxiety, an antihistamine known as Vistaril can be given every 4 hours at 25 to 50 milligrams. For patients experiencing insomnia, trazodone, an antidepressant, is sometimes used. This should be taken 30 to 60 minutes before bedtime. The dosage can be 50 to 100 milligrams. This can depend on whether or not patients feel overly sedated in the morning following taking trazodone. Another drug that is often used is antihistamine called Benadryl. This is commonly in medications, any kind of PM, Advil, or Tylenol will contain Benadryl. And again, the option is for 25 or 50 milligrams, and it should be taken 30 to 60 minutes before bedtime. For nausea, Zofran, an antiemetic, at 8 milligrams is given. It's best if this is taken as soon as nausea develops and before the patient has vomited. Other medications sometimes used are gabapentin, also known as Neurontin. This drug is an anticonvulsant, but it has anxiolytic and sedative effects. Let's move on now to the management of opiate withdrawal syndrome. As previously mentioned, opiate withdrawal, while extremely uncomfortable, is not life-threatening. Therefore, detoxification from opioids can be managed in an outpatient setting, such as a physician's office, an intensive outpatient program, or a methadone clinic. A hospital emergency department may serve as the initial point of contact with health services for the patient who has overdosed, for example. One advantage to inpatient detoxification is restricted access to the substances of abuse. In an inpatient setting, clinicians also have the opportunity to develop and implement plans for further treatment. Let's look at some of the early and advanced symptoms of opiate withdrawal abstinence syndrome. As mentioned earlier, the signs and symptoms of opiate withdrawal syndrome begin from 8 to 12 hours following the client's last use. They do subside over a period of 5 to 7 days. With opioids such as methadone and buprenorphine, the symptoms begin 12 hours after the last dose, peak on the third day, and gradually subside. These may continue for 3 weeks or longer. The signs and symptoms of opiate withdrawal resemble a severe case of the flu. The initial symptoms include anxiety, increased respiratory rate, sweating, tearing, yawning, runny nose and sneezing, goosebumps, restlessness, lack of appetite, irritability, and dilated pupils. The advanced symptoms are insomnia, nausea and vomiting, diarrhea, weakness, abdominal cramps, rapid heart rate, elevated blood pressure, muscle spasms, as well as muscle and bone pain. As with the alcohol withdrawal, we have a scale for opiate withdrawal known as COWS. COWS is an 11-item scale for assessing withdrawal from opiates and can be administered in about 2 to 5 minutes. Like CIWA, COWS is not copyrighted and can be used freely. It assesses resting pulse rate, sweating, restlessness, pupil size, bone or joint aches, runny nose, GI upset, tremors, yawning, anxiety, and gooseflesh skin. This tool can be used in both inpatient and outpatient settings to rate the severity of symptoms as well as their improvement over time. Some clinicians consider this not to be objective enough. However, many symptoms of opiate withdrawal are observable. One medication used to treat opiate withdrawal is Clonidine. This drug is marketed for the treatment of hypertension or high blood pressure. The drug is also known as catapress. It can cause hypotension, which is low blood pressure. Therefore, we have to monitor the blood pressure, and we withhold the dose if the diastolic or bottom number is below 60. The dosage is generally 0.1 to 0.3 milligrams. This is taken orally 3 to 4 times daily. It does not produce euphoria and is therefore not addictive. It has some advantages over methadone for the treatment of narcotic withdrawal, particularly in drug-free programs. Also, it alleviates some symptoms, but it's not effective for muscle aches, insomnia, or drug craving. Another advantage is that it can shorten the amount of time needed before naltrexone, which is an anti-craving medication, can be instituted. Methadone, while commonly thought of as a maintenance drug, can also be used for withdrawal from heroin, fentanyl, or any other opiate. This may be the best option for patients who have relapsed after multiple attempts to become drug-free. It is a long-acting opiate agonist. It does produce physical dependence of the opiate type. It can only be administered in licensed facilities due to the risk of misuse and diversion. For the treatment of withdrawal, the dosage is 20 to 30 milligrams per day until stabilized, and then the dose is tapered gradually over 6 to 10 days. This is especially recommended for patients who may benefit from daily dosing, and Suboxone is a drug which combines buprenorphine with naloxone. Naloxone is an opiate antagonist, whereas buprenorphine is a long-acting partial agonist. We must wait until the patient is experiencing mild to moderate withdrawal symptoms before taking the first dose. Otherwise, they might experience a precipitated withdrawal due to the naloxone. The dosage is 0.8 to 4 milligrams per day, to a maximum of 35 milligrams per day. This is then tapered gradually. This drug comes in sublingual tablets or film. It can be prescribed in an office-based opiate treatment by a licensed provider. Suboxone minimizes the risk of diversion and IV use, because when it's dissolved in water and injected, the opiate antagonistic effect is realized. Some of the comfort medications used for opiate withdrawal include acetaminophen or Tylenol every 4 hours. For muscle, joint, and bone pain, ibuprofen or Motrin, 600 to 800 milligrams can be given every 6 to 8 hours. To treat anxiety, Vistaril 25 to 50 milligrams can be given every 8 hours. For abdominal cramping, Bentyl or dicyclomine can be given every 6 hours. The dosage is 10 milligrams. For diarrhea, Imodium 2 to 4 milligrams can be given as needed. Indigestion can be treated using Mylanta 30 cc's between meals. Moving on to benzodiazepine withdrawal. Dependence on benzodiazepines and other sedative hypnotics often develops in the context of medical treatment. These drugs are extremely effective in treating panic disorders. Therapeutic discontinuation can be managed by the patient's physician by slowly tapering the substance over several months. Patients on low-dose benzodiazepines often experience what's known as symptom rebound. This is a temporary increase in symptoms for which the patient was being treated. Patients who are addicted to opiates and stimulants may misuse benzodiazepines, sometimes to the extent that they develop dependence. In this case, detoxification from the sedative hypnotic must be addressed. Without medical treatment, withdrawal from benzodiazepines can be severe or life-threatening. Signs and symptoms include anxiety, tremors, nightmares, insomnia, lack of appetite, nausea, vomiting, orthostatic hypotension, which is a drop in blood pressure when getting up from a lying position or sitting position, seizures, and delirium. If a patient is to experience withdrawal delirium, this generally follows a period of insomnia. With short-acting benzodiazepines, withdrawal symptoms typically begin 12 to 24 hours after the last dose and reach a peak intensity between 24 and 72 hours. Medical management is always needed with high-dose benzodiazepine withdrawal and is best provided in a hospital. Phenobarbital substitution is the most generally applicable. It allows for the safe use of a progressively smaller daily dose. When looking at withdrawal from stimulants, such as cocaine and methamphetamine, intermittent binge use is common. Following a 2 to 3 day binge, stimulant abusers are often dysphoric, exhausted, and somnolent. This lasts for 24 to 48 hours. Because cocaine abusers often take alcohol and marijuana to reduce irritability, the withdrawal symptoms may be in response to the combination of drugs. Following regular use, the withdrawal syndrome consists of dysphoria, irritability, difficulty sleeping, and intense dreaming. These symptoms usually subside over 2 to 4 days of abstinence. There is no specific treatment for stimulant withdrawal, although patients may be given something to help them with sleep. There is no acute abstinence syndrome associated with withdrawal from marijuana. Some patients do experience irritability and insomnia. Regarding nicotine, many programs are now instituting smoke-free environments. Some programs treat nicotine as a drug of abuse and require patients to quit smoking as part of their chemical dependency treatment. Nicotine patches and gum are often offered to manage physiological withdrawal. Hallucinogenic drugs do not produce withdrawal syndromes. There is some evidence that withdrawal from inhalants is similar to withdrawal from alcohol. Therefore, phenobarbital may be prescribed during detoxification. Persons with substance use disorders rarely use just one drug. In those cases, treatment proceeds as follows. For someone using alcohol and stimulants, we treat alcohol abuse first. For someone using alcohol and benzodiazepines, the patient is treated with phenobarbital. For cocaine and benzodiazepine, we must treat the benzodiazepine withdrawal. Cocaine and opiates, we treat the opiate dependence. Moving on now to post-acute withdrawal syndrome. Post-acute withdrawal syndrome, sometimes referred to as PAWS, as well as protracted withdrawal. Protracted withdrawal is the presence of substance-specific signs and symptoms common to acute withdrawal, but persisting beyond the generally expected time frame of acute withdrawal. Most clients in treatment for substance use disorders do not immediately feel better. In a pattern unique to each client, symptoms related to substance use may be felt for weeks, months, or sometimes years. Clients may be affected by less intense versions of the acute withdrawal symptoms, as well as impaired ability to check impulses, negative emotional states, sleep disturbances, and cravings. These symptoms may lead the client to seek relief by returning to substance use. Not all clients experience protracted withdrawal. Still others may have initial clearing of symptoms, sometimes known as a pink cloud, for the first month or two, and then develop unpleasant symptoms later on. Chronic substance use causes molecular, cellular, and neurocircuitry changes to the brain that affect emotions and behavior, and that can persist after acute withdrawal has ended. Research on pause is limited, and because of this, it is not included in the Diagnostic Manual, or DSM. The symptoms of pause may lead clients to return to substance use to get relief. The symptoms for each substance class are similar but not identical. And these symptoms can persist intermittently for up to 2 years. Repeated use of a substance causes the brain to respond more readily to its effects, but less readily to naturally rewarding activities, such as listening to music. This state in which a person's ability to experience pleasure is decreased is called anhedonia. Many people in early recovery also show deficits in their executive control functions, and these may persist for months beyond the acute withdrawal period. In the case of cocaine, a 2007 study in the Journal of Drug and Alcohol Dependence showed clients had significant improvement in emotional regulation after 4 weeks of abstinence. However, their impulse control had not improved. Once addicted, the brain is changed. The top row shows normal brain activity as indicated by the yellow areas. Row 2 shows brain activity in someone who has used cocaine for 10 days, showing dramatically decreased brain activity. Row 3 shows the return of brain activity after 100 days of abstinence. In many 12-step programs, they recommend that people attend 90 meetings in 90 days. As you can see from this slide, the first 90 to 100 days is a time when the brain is healing, but it is nowhere near to normal functioning. This is why continued treatment is recommended. The longer a client can remain abstinent, the better his or her chances of sustained remission. After a year clean and sober, the chances of sustained remission increase 30 to 50%. Some of the possible symptoms of pause include those under the category of cognitive. These would be racing thoughts, confusion, feeling easily overwhelmed, difficulty with memory, a loss of previously learned skills, mental obsessions, being easily distractible, as well as dissociation. Emotionally, the client might experience frustration, moodiness, the pink cloud, anger, anxiety, feelings of hopelessness, difficulty feeling pleasure, and depression. Some of the physical symptoms might include sleep disturbances, exhaustion, pain issues, over or under eating, digestive issues, as well as being accident prone and experiencing agitation. PAUSE is a framework that helps us to explain the brain and biological changes that people go through in early recovery. One of the most important things that we can do is to normalize our client's experience, provide reassurance that while unpleasant, pause is normal and symptoms will gradually improve. You could liken it to a traumatic brain injury. It takes time for the brain to heal and regain full functioning. It's also important to help clients develop realistic expectations. Pause is often described as a time of emotional roller coaster. In the early days of recovery and post-acute recovery, the client might have periods of time just feeling miserable. As time goes on, sometimes okay, sometimes not. That first decent night's sleep can be a really big turning point. Appetite improves, and gradually they experience moments of peace. And now it's time for another discussion question. Cognitive symptoms of pause may include racing thoughts, memory problems, confusion, or all of the above. The answer is all of the above. These are all possible symptoms that persons in early recovery might experience. Moving forward, one of the important things that we can help as clinicians is for our clients to develop adaptive coping skills. Celebrating each accomplishment, advising our clients to be patient. Recovery takes time. As the symptoms of withdrawal and acute withdrawal, post-acute withdrawal begin to clear, we want to make sure that we're continuing to assess for co-occurring disorders. It's important to encourage clients to be physically active. This can particularly help with anxiety as well as sleep problems. Encouraging participation in mutual self-help groups decreases the feelings of isolation. We can also discuss aspects of self-care, good nutrition, getting enough rest, doing something every day that gives them a feeling of pleasure or mastery. Some other things that are often helpful are relaxation techniques, yoga, and meditation. One of the biggest problems for many people is insomnia. There's nothing worse than wanting to sleep and not being able to. Patients can be encouraged to create a sleep ritual. This is sometimes called sleep hygiene. Some strategies are to write down pressing concerns that can be dealt with tomorrow. Having a light snack, banana, some crackers, or a cup of decaffeinated tea such as chamomile can also help prepare the body for sleep. You might encourage the client to practice some yoga or to meditate. Taking a hot bath or a shower before bedtime helps to stimulate the release of melatonin, which is our body's natural sleep hormone. Another strategy is to block out distracting noise, especially in a treatment center. We often offer earplugs for that purpose. Many clients find that listening to relaxing music helps to still the thoughts racing through their minds. In addition, they want to make sure that their room is dark. Having a darkened room also stimulates the release of melatonin. Although it may seem silly, gently saying to yourself, "Not now," when you wake up in the night and your thoughts begin to race. Another major area of concern for many people is anxiety. Many people in early recovery experience a lot of anxiety, worry, as well as feelings of being overwhelmed. Some simple things to do are to look up, look around, notice what's around you. Notice that right here in this present moment, you are okay. Turning your head from side to side stimulates something called the Orienting Response. This is seen in many animals, such as a deer, when startled, will lift its head and survey the surrounding area. This reassures the client that they are safe and helps to shut off the anxiety. Practicing taking deep breaths, particular breath exercise is to inhale to the count of 5, suspend the breath for 5, and exhale for 5. This can be repeated as many times as needed until the person begins to feel less anxious. Reminding oneself to lower the shoulders. Notice if they're gripping or tensing, the jaw, the hands. Sometimes we're not even aware that we're holding tension in the body. Another strategy is to just talk to yourself. Scruff your face and change your perspective. A gratitude list can often be effective in helping to change perspective. Our brains are hardwired to the negative, so we have to work a little harder in order to change the perspective to something more positive. Another thing that is very difficult for many people in early recovery is how to cope with cravings. Cravings are a normal part of early recovery and can be managed with proper treatment. If left untreated, though, they can lead to relapse. It's very important to have a plan for coping with these uncomfortable and intense sensations. Fortunately, they will always subside if you can ride them out. Their strength and frequency will decrease the longer you abstain from using drugs and alcohol. In an article after Philip Seymour Hoffman's relapse and subsequent death due to overdose, the author said, "Whoever you are, wherever you are, whatever your background, you could not possibly stand toe-to-toe against this craving for opiates if it was initiated in you. It feels bigger than you. It feels like you're trying to fight a full-grown tiger with your hands tied behind your back." Defining craving. Craving is a physiological reaction to withdrawal from an addictive substance. It can be a way of escaping from unpleasant feelings such as boredom, depression, or anxiety. It's also a learned response to certain associations, people, places, and things. It can also be a desire to enhance a positive mood. Once addicted, the body and brains crave alcohol and drugs to function normally. Cravings are generally most severe in the early months of recovery, from 0 to 6 months. They are the #1 reason for relapse, and patients are particularly vulnerable during that first year. There's a small part of the brain called the Insulin Cortex, which reads body states like hunger and craving, and helps push people into reaching for the next sandwich, cigarette, or drink. With smoking, for example, it's not just nicotine binding to the parts of the brain, but all the associated sensations: increased heart rate, that tickle in the lungs, a taste in the mouth, the positioning of the hands, all the rituals that go along with smoking. Just the mention of items associated with drug use may trigger the person with substance use disorder to crave or desire the drug. This slide shows the amygdala of the brain of someone who's viewing a nature video on the left. On the right, the amygdala is shown in someone who's viewing a cocaine video. As you can see, the brain lights up like a Christmas tree, just at the memory of the drug. Thankfully, we have medication-assisted treatment for alcohol use disorder, as well as opiate use disorder. The two drugs often used for alcohol use disorder are naltrexone and acamprosate or Camprel. We'll just talk for a moment about comparing these two drugs. Naltrexone blocks the brain opioid receptors, and this makes alcohol use less rewarding and therefore reduces cravings. The most common side effects include insomnia, stomach upset, anxiety, headache, and fatigue. Generally, these side effects will subside within a week or two after initiating treatment. The issue with alcohol use disorder and naltrexone is that it is contraindicated in patients with liver disease. So they need to be screened to make sure that they don't have liver disease before initiating treatment. Acamprosate, or Camprel, normalizes alcohol-disrupted brain activity and reduces craving. The most common side effects include diarrhea, itchiness, dizziness, headache, insomnia, and anxiety. This drug is contraindicated in patients with renal disease. One of the main downsides to this drug is that it must be taken 3 times a day. When looking at medication-assisted treatment for opioid use disorder, the primary medication given is naltrexone. Oral naltrexone will block the pleasurable effects of opiates and helps to reduce cravings. The patient must be through the acute withdrawal period, 7 to 10 days of abstinence, before initiating naltrexone therapy to prevent precipitated withdrawal. A naltrexone challenge is done before starting Vivitrol, which is the injectable form of naltrexone. Patients receive their Vivitrol injection once a month. Each month, they are making that commitment to stay clean and sober for the next 28 days. The injectable form has much better compliance than oral naltrexone. It is possible to override the effects of Vivitrol toward the end of the month when the drug level is lowest. It's important to ask clients if naltrexone is right for them. Are they willing to commit to long-term abstinence? Are they willing to continue with counseling and/or group therapy? Do they understand that naltrexone or Vivitrol treatment is a tool but not a cure? And do they also understand that decreased tolerance can lead to risk of death from overdose? There are some non-medical strategies to coping with cravings. Delay. Don't give in no matter what. Remember that cravings will disappear in 10 to 15 minutes if you don't continue to fuel them with your thoughts. Escape. Have an exit strategy to physically remove yourself from any urge-provoking situation. Accept. Keep things in perspective. Remember that cravings are normal and will subside. Cravings won't kill you, but drugs or alcohol might. Substitute. When you get a craving for drugs or alcohol, quickly substitute a thought or activity that is fun or beneficial. Imagery. Command your cravings to stop. Visualize a big stop sign. Refocus your attention on a relaxing location of your choice. And lastly, encouraging clients and reminding them that they can do it. Underlying the overwhelming desire for a substance is often a deeper need, perhaps relief from challenging emotions, or a desire for joy, peace, or freedom. Thank you for joining me today as we explored therapeutic approaches to managing withdrawal.